Hi there, my name is June, and I'm going to show you a demonstration of an intramuscular injection. I'm going to show you how to landmark safely for that injection. I'm going to show you how to safely prepare and administer the medication as well. So if you follow me over here, you can see that I have two stations set up. Here is going to simulate our medication room, our med cart, our Omnicell, wherever we would be preparing the medication. And if you'll look behind me, you can see that I have a simulated patient room. So Jesse is in his bed, and this is where we're going to go to do the parts of our skill that are required. So for starters, let's build a little scene and say that arriving on shift, it's a brand new shift in the morning, and as I open or walk into the nurse's station or nursing unit, I find that my patient's chart is open and there's a doctor's order that has been written and by the night shift before, and that has been transcribed by the nurses before, and so I'm just going to do my checks. And so the first thing I'm going to do is some hand hygiene, and then the first step in safe medication preparation is to take a look at my doctor's order. I'm checking my doctor's order to make sure that I have all of the components that make it complete and accurate. Those include the doctor's name, the patient's name, the patient's date of birth and or health card number, any allergies, and then for the drug, I want the drug name, I want the drug dose, the route, the frequency, a date and time that is current, and the doctor's signature. And so if you look over here at our first doctor's order, you can see that we have a patient name, we have a health card number, we have a date of birth, we have any patient allergies. Our patient does not have any allergies. And then if you look down at our first drug, you can see that we have an order for vitamin B12, and we have both the trade and the generic. We have a dose, which is 1,000 micrograms. We have a route, which is intramuscular. We have a frequency, which is monthly, and we have a doctor's signature. So that's great. My doctor's order is complete and accurate. I don't have to call the doctor back and clarify anything. If any of those components are missing, that's my responsibility to correct any and clarify anything that's missing from there and refax and have the doctor sign it as per our agency policy. Once I've determined that the doctor's order is complete and accurate, then my next step is to compare it to the medication administration record, or the MAR. That's the next very important document in our safe medication preparation. So a MAR is a medication administration record, and we can see here, if we look down and we start comparing our doctor's order to our transcribed MAR, we can see that we have vitamin B12, we have vitamin B12, we have 1,000 micrograms, 1,000 micrograms. For the route, I have intramuscular. Look at that, I have a route intramuscular. For frequency, I have monthly, and for frequency, I have monthly. I have the patient's name, I have their date of birth, and no known allergies. So all of those components so far have transcribed accurately. Two nurses, as I've explained to you in previous discussions about safe medication preparation, mean that a MAR has to be transcribed or checked by two nurses. The first nurse who transcribes or copies that information to the MAR puts her initials first, and then a second nurse has to check the doctor's order against the MAR and make sure that both initials are there with a date. I have zeros there because I would be changing the dates so often, but just to give you guys the context. And then you can see that this is the master signature part of our MAR that we've discussed as well, and you can see that we have two signatures and we have two initials. So that means after I've actually given this medication later today, I'm going to sign my MAR and I'm going to date and time it appropriately, and then if anybody comes behind me and needs to check on that medication, they can figure out whose initials are JD by this master signature. Okay. So once we've determined that our MAR has all the components it should, it's transcribed accurately, we can put our doctor's order aside. We don't really need that any longer, and we can work from our MAR for the rest of our preparation. The next thing that is so important to do as we start to think about the rights of our medication preparation and administration is to look in the drug guide and educate ourselves so that we can go and educate our patient. So we're starting to think about our rights right away. And so when I take out my drug guide, I might be a new nurse, or you might be a new nurse, and you've never heard of vitamin B12 before. You don't know what it's for, you don't know how much a patient should have, you don't know what any of the side effects could be, you don't know how quickly it begins to work, so onset, peak, and duration. You don't know any of the assessments that are necessary, so you need to educate yourself. You can't go in and prepare and give this medication until you know why you're giving it and what for. So you take out your drug guide and you're going to look up all of those components and check for onset, peak, and duration, any implications for nurses, any contraindications. When you're happy with all of that and you feel like you're very knowledgeable about that drug, you can then, next step, is take out your patient's chart and make sure you've looked through anything that is pertinent. Is this brand new drug that your patient is taking? Has Jessie ever had it before? Is there any history about how Jessie feels about injections? Anything you need to know, you're going to find it in the patient's chart. When you're happy with all of those things, now you can safely go in and begin to apply some of those rights and give Jessie the right education and the right to refuse. So we're going to do that now. So I'm going to enter my patient's room. So I'm coming into the room and I'm providing privacy as necessary for my patient. I'm going to start with some hand hygiene in front of my patient. That is so important. And then I'm going to introduce myself. Hi Jessie, my name is June and I'm going to be your nurse today. Would you please tell me your full name and your date of birth? He's going to tell me his name is Jesse Moore. He was born April 2nd, 1998. I'm going to confirm that on your name band, Jessie. So I'm going to lift up his wrist and I'm going to double check that I have Jesse Moore. Then I'm going to explain to Jessie that the doctor has ordered a vitamin B12 injection. I'm going to explain what it's for, see if Jessie has any questions about the drug. I'm going to be watching Jessie for any nonverbal cues. Is he running out of the room or is he okay with the injection? That's all really important. We're going to talk about where we're going to give that injection. This is going to be a ventrogluteal injection today, our preferred site, and we're going to demonstrate that in a little while. After I've given Jessie all of the education and he's happy with everything, Jessie then has the right to refuse. And so when I say, is that okay? And he says, yeah, I'm okay with that. You can go and get that ready. That's him giving you consent. So we've just applied a couple of rights. We've got the right patient. We've given the right education. We've given the right to refuse. We have checked in our Davis Drug Guide all about it, so we know the right reason. We know from blood work in Jessie's chart that he's deficient in vitamin B12. So we're starting to apply those rights, and it's kind of an ongoing. I don't want you to memorize the rights. I want you to understand what they're for. And so when we're happy with that, we're going to leave the room and go back to our medication preparation area, and we're going to prepare our drug. So I've selected my equipment already. I have my MAR here. I'm ready to work with that, and I'm going to perform some hand hygiene before I begin preparing my patient's medications. So for an intramuscular injection, I need, I'm going to choose a 3 ml syringe. I'm going to be aspirating my medication from a vial, which is a closed system, a negative pressure closed system, so I'm going to discuss that with you. I need a filter needle for a blunt fill needle for aspirating the medication out of the vial, and I need a finish needle for an intramuscular injection. And so today I've chosen what our usual typical standards are for a normal tissue mass in a young adult or an adult. It is a 22 gauge 1.5 inch finish needle. That's a fairly long needle. That needle has to reach right down deep into the muscle, so through the epidermis, through the dermis, through the subcutaneous or adipose tissue, and into the muscle where there is a vast blood supply, and we want it to stay in there. So we'll also talk about the Ztrack method when we get to the hip and we talk about our Ztrack method. We're also going to talk about aspirating in an intramuscular injection, and so you're going to, as a new nurse or a graduate out there, follow the agency policy. aspirating medications tends to trend in and out with best practice evidence from research. And right now, aspirating is not widely used, but we're going to show you how to do that anyway, just in case you need to know how to do that. So those are my materials. I have some alcohol swabs, and so I'm ready to get going. So now let's start to talk about our checks. We do 3 medication checks. That's a minimum. That's a standard minimum that we do when we're preparing medication. So the first med check that I do is my first encounter with the medication, wherever I'm getting it from, the med cart, the Omnicell, the medication room. That's my first encounter. That's my first check. So I'm going to physically pick up my medication, and I'm going to compare the label and the expiry date and the concentration, everything with the MAR. So I'm looking right at my MAR and seeing that I have vitamin B12, cyanobalamin, and I can see on my vial that's exactly what I have. So I have the right drug right now. If I want to start at the top and say right patient, I just went in and talked to Jessie, so I know I have the right patient. I have the right drug. The dose is 1,000 micrograms. My vial of medication says that there are 1,000 micrograms in every mil. So right away, I have determined that I will need 1 mil of this medication. So I've done math. I don't have the right dose yet, but I will. As soon as I begin to draw it up, I can call that my right dose. I know the right reason. I've checked the drug guide. I've given my patient the right education and the right to refuse. I've done the right assessment, and I know that documentation, which is signing my MAR, and evaluation are going to happen at the end. So I'm acknowledging those rights that I can't apply right now, but I'm acknowledging them. That's my first check. So now I'm ready to begin my preparation, and so I'm going to take the top off of my vial, and I'm going to swab the top of my vial for a good 10 to 15 seconds. We want to really scrub that top to make sure we've removed any microbes. And while that's drying, I'm going to prepare my supplies, and I'm going to create a little cradle that maintains the sterility. That syringe has a sterile end, and this filter needle is sterile as well, and we don't want anything to touch that. So I'm going to peel down and I'm going to expose my hub. That's the hub. And I'm going to pick up my syringe. That's sterile. So only sterile can touch sterile. So I'm going to attach that. I can take that off. And now I have a safe closed system. So that can sit in the cradle for now. I'm also going to just get my 22 gauge 1.5 inch needle ready so that I can grab it with one hand and just attach it when I remove this needle after I'm done aspirating my medication. So I'm just going to peel it open a little bit just to expose it, but not let it touch any surface. So it's still sterile in there and it's safe. So I'm getting ready to prepare my medication. So let's go ahead and do our second medication check, and we'll start right from the top with our patient name. Do we have the right patient? Yes, we went in and we talked to patient and identified our patient. We confirmed it with the medication band on their wrist, or their name band, sorry, on their wrist. And when we go back in with our prepared medication, we will do a second identification where we ask the patient to tell us their full name, and we compare it to their name band and to the MAR that we bring into the room. So it's so important to make sure you have the right patient. So right patient, right drug. It is vitamin B12. I have vitamin B12. The dose is 1,000 micrograms. There are 1,000 micrograms in every mil. I'm going to be drawing up a mil. I know the right reason, and I know I've given Jesse the right education and the right to refuse. I'll give it to him again when I return with my injection to give him. And evaluation and documentation are ongoing. I will talk more about that when we get there. So that's my second solid check. I'm feeling really good that I know I have the right drug and the right patient, and soon I'm going to have more of those rights. So I'm careful not to touch the top of that swabbed vial as well because, sorry, I have an itchy nose. I'm just going to, my hands again. I'm ready to start preparing it. So I mentioned to you before, this is a closed system. It's under negative pressure. And what that means is that we've got to add some air to it in order to release some of that negative pressure and make it a little easier for us to draw up our syringe. So we never touch this part of the syringe. We keep our fingers down here on the end so that we maintain that sterile inside after your little circle to hold on to. We can see the increments of our syringe. Okay. And we are going to be drawing up 1 ml of medication, or aspirating 1 ml of medication out of there. So we're going to draw up 1 ml of air. It's always the equal amount. So I'm going to draw up 1 ml of air. I'm going to pull my cap off straight and away from myself. I'm going to set that down right in front of me. I'm going to grab my vial. I'm going to stabilize it on the table in front of me. I'm going to turn my syringe just like a dart, and I'm going to pierce that top. I'm just keeping if you look through that little window, you can see that I'm keeping my needle above the fluid right now. So I'm going to set that back down on a firm surface just to show you. And I'm going to use my thumb as my powerhouse. That's the plunger that pushes the air down. You can see if I release my thumb, the air pops right back up into the syringe. So it's important for you to leave your thumb holding that air into the vial, and then I'm going to move everything in one movement. I'm going to invert the whole system, and then I want you to look through that window again and see that I've got my needle well submerged in the fluid. Okay? So as I start to release my thumb, that's going to fill nicely for me. And I may have to manipulate it a little bit myself. So I'm going to stabilize it like this so that I can look at it. And I'm going to flick out any air that I have. See a little bit there. There you go. I'm keeping my needle well submerged. And I'm just pulling down while I have it stabilized here. I'm not letting any part of my fingers touch that sterile hub of the needle or the red part. And I'm going to just draw down to 1. And if you want to draw just a little bit extra, that's fine too. You can go ahead and do that. So you can see I have a nice clear, there's no bubbles or anything in there. That's why it's so important to keep the needle submerged in the fluid. When I'm happy with that, I'm going to put everything back the way I found it. I'm going to pull my syringe out. I'm being careful not to let my palm touch the plunger now because I'd lose some of my fluid if it pushed on it. And I'm going to just recap with one hand because we never recap with 2 hands. I'm going to just scoop that up and I'm going to recap it. And then what's really important to remember is that 18 gauge filter or fill needle has a large drop of this medication in it. And we want that drop of medication because we use it to prime the air out of our finished needle. We never inject air into our patient, and so this brand new 1.5-inch needle has air in it. And so we need to prime the needle. We prime a needle by pushing the air out with fluid. So I'm going to, before I remove this needle, pull that plunger down and get that drop. It falls down out of that hub into the syringe. When I'm happy with that and I know I have 1 ml and maybe a tiny little bit more, I'm going to go ahead and remove this. I'm going to hang on to it just in case I need to grab it again. I'm going to drop it right into that little sterile cradle that I made. And I'm going to pick up my finished needle. I'm holding on to my syringe and I'm keeping this sterile end sterile. And I'm going to fold down those edges without letting anything touch my syringe. Very important. Sterile can only touch sterile. And I'm going to screw that on. That's good. That's all done. It's important to keep a clean and tidy work site as well so that there's nothing there to confuse you. It's also really important to not be distracted by other things going on around you when you're preparing medication. So we're almost there. I'm going to give that a couple of flicks and make sure there's no bubbles in it, and then I'm about to prime. Priming means I'm going to push the air out of this needle by pushing fluid through it. So you can see that I have a gap between where my medication is and the top of the syringe. And as I start to advance this needle up, I'm going to just show you and then I'm going to turn it so I can see. If you watch closely at the top of that needle, you'll see a couple of drops fall off the top of that needle. That's a primed needle and it has exactly 1 ml. So you must finish with a primed needle and the exact dose. 1 mil. Okay? So now I'm ready to do my third and final check of my medication. So I'm going to pick up my vial, and I have my syringe now. I'm going to do my third check, and I'm going to start right from the top. I have the right patient. I went and seen Jesse. I identified him. I checked on his name band. I know he's the right patient. I know he's not allergic to vitamin B12 because I checked in his chart. I made sure. I talked to him. I asked him lots of questions. And then I'm going to move on. Do I have the right drug? It's vitamin B12. My vial says it's vitamin B12. Do I have the right dose? The MAR says I should have 1,000 micrograms. My vial says there are 1,000 micrograms in every mil. I drew up 1 mil. I have 1 mil here. I have the right dose now. I know the right reason. I've given Jesse the right education. I've given him the right to refuse. Documentation is when I sign the MAR only after I've given the medication, and evaluation is ongoing. It's something that I'm checking on my patient at the end, 15 minutes later, after I've administered this injection. Okay? So I have a nice safe drug there. I feel really good about this. This can be dropped into the sharps now because I don't need that anymore. This is all nice and good to go. You can put that over there. And so now we're going to move on to the next step of our preparation, which is to return to our patient's room. We're going to identify our patient again. It's absolutely essential that you identify your patient before you are about to give your medication again, and that you compare it to the MAR. That's your last check to make sure you have the right patient to give the right drug to. You know your drug is good. Now you have to make sure that your patient is the right patient. Okay? So I'm going to grab some gloves here, and I'm going to take my pen, and I'm going to take my MAR and my drug, and I'm going to head to my patient. So I'm entering Jesse's room now. Hi Jesse, it's June again. I'm back with your injection that we discussed. Are you still okay to have that injection? And he's going to say yes or no, and I'm going to say, can you please tell me your full name again and your date of birth? And he's going to say, my name is Jesse Moore, and I was born April 2nd, 1998. And I'm going to say, may I just check that against your name band one more time, Jesse? And I'm going to check that name band as I look at my MAR. I'm going to make that comparison that I have Jesse Moore, April 2nd, 1998, and perhaps a health card number. And so now I feel really good that I have the right medication, and it's for the right patient. Okay. So I'm going to do some hand hygiene if I didn't do that already when I entered the room before I touched my patient. And now I'm ready to give the injection. So I've closed the door, I've provided privacy, I've exposed only the area that I need to on my patient. That's going to be on his hip, the ventrogluteal site today. So you only apply your gloves when you're ready to actually give your injection. So I'm going to put on my gloves. And I'm going to just grab an alcohol swab right here. And so we're going to imagine that our patient is in the bed as Jesse is now. And so normally your hip would be this way. It's going to vary depending on where your patient needs to have their injection. They may have had surgery on one hip, and so it has to be on the other hip. Or they may have broken one hip and you have to use the other hip. There's a couple of tips that are really important so that you know you have landmarked correctly, so that you don't hit a nerve. So I'm going to turn this way just for your ease. I'm going to show you that I'm just going to stand at the end just to make it a little easier for you. And I'm not actually going to inject the needle, but I'm going to go through the steps so that you can see a thorough demonstration and explanation of this. So the first tip for you to remember when you're landmarking for a ventrogluteal injection is that your thumb, you want to choose the hand to locate that makes your thumb point to the groin. Okay? So Jesse, we're going to pretend that this is going to be Jesse's right hip. And I'm going to start with my left hand. My thumb will point to that groin. I'm going to start nice and low down here. And in real life, when you start to landmark on real people, you have to push fairly good. It's actually, your patients usually will say that, ouch, that hurts a little bit. But you need to locate that greater trochanter, the hip bone, And if you move your own leg, you can feel that greater trochanter. So when they're laying there, you may ask them to flex their leg a little bit, start down low and start to push your way up. Thumb to the groin. The thumb is pointing in. And as you push, you want your fingertips to reach the greater trochanter, the bottom of the hip bone. And when you feel that bone under your fingertips, let your palm fall on top of those fingertips. When you stretch out your fingers, your thumb is pointing to the groin, your index and middle finger are pointing to the iliac crest and spine, and there's your wonderful safe zone right there. So that little piece of pie that I create, and if you look on this side where they have an open section, you can see that deep muscle. We want to reach that deep muscle and avoid any nerve endings. So once I have that spot all fixed and ready to go, then I can open up my alcohol swab, and I'm going to clean a great nice area there in between. But then I'm going to use my alcohol swab and the point of it to landmark, because I need to take my hand away in a second. So I'm going to lay my alcohol swab down. Now I can remove my hand, but I know I'm going to inject right in front of that alcohol swab. So I'm ready to do that. I would grab my syringe, I would pull my arm down and pull the cap off. Now we're going to talk about our Z-Track. Z-Track is a method to displace the tissues so that when we inject the medication that can burn and sting, we want it to stay locked in that muscle. So when we displace those tissues using Z-Track, when we pull our syringe out and release our hand, those tissues all seal over and keep the medication closed in down in the muscle. So it's an important part of our technique. We do that by placing our non-dominant hand against the hip, and we just apply some pressure and pull laterally away. So I'm pulling away towards the wall, and then I'm ready to inject. So I would pierce the skin right in front of the alcohol swab, stabilize. Then I'm going to aspirate. So I'm going to pull up on this syringe and see if I've hit a blood vessel. That would mean a shot of blood inside that syringe. If that happened, I would pull the needle out, discard the needle. I would have to go and prepare a new one again. You can't inject into the blood vessel. That's according to agency policy. We don't see blood, so I would go ahead and inject at 1 mil per 10 seconds, wait a few seconds, release my stabilizing fingers, but not my Z-Track. I'm holding tight to that Z-Track, displacing the tissues. I would release those stabilizing fingers, pull the syringe straight out of Jesse's hip, release the Z-Track, closing over those tissues, and apply gentle pressure for 10 seconds on the injection site. My thumb would come up in one hand and lock that blade so that I couldn't stick anybody, myself especially, and I would drop that immediately into the sharps container right here. We're going to go ahead and do that injection on the injectipad just to finish and follow through with her. Okay, so I would have returned Jesse to a comfortable position, covered him, made sure he was comfortable, made sure the call bell was there, and we'll talk about all that again. So now I'm going to come back to my med room, and I'm just going to finish up, follow through with this injection for you. So over here at my injectipad, we're going to pretend this is our patient, Jesse Moore. I'm going to go ahead and swab that big 5 centimeter circle again, and remember it's that scrubbing, mechanical scrubbing, that reduces the microbes on the skin before we inject and pierce the skin. So that cleansing is really important. And then I'm just going to let the alcohol swab make a point, just like I did just on the hip. I'm going to follow through. I'm going to show you the rest of this. I'm going to pull down my arm. I'm going to pull off my cap straight and away from myself. My non-dominant hand is going to apply pressure and move laterally. I'm pointing laterally away. I'm going to inject this needle right to that black hub. I'm holding my syringe just like a dart, and I'm going to very deliberately pierce the skin all the way to the hub, stabilize. I'm holding my Z-Track here. I'm going to aspirate, and it looks just like that. It makes kind of a bubble. No blood. I'm going to inject. I'm going to wait a few seconds. My dominant hand is grabbing the syringe again. I'm releasing my stabilizing fingers, but not my Z-Track. Now I'm pulling that syringe straight up and away. I'm going to lock that blade. I'm releasing the Z-Track and applying gentle pressure for 10 seconds. And I'm going to drop that right into the sharps container where it's safe. I would return Jesse to a comfortable position, cover him, give him the call bell, make sure he had everything that he needed. I would tell him I would stay with him for a few minutes while I'm talking to him. As I'm removing my gloves, I'm going to do some hand hygiene. We always perform hand hygiene before we apply gloves and after we remove them. No exceptions. While I spend a few minutes with Jesse, now I can complete one of the next rites, which is rite documentation. So I'm going to go ahead and put in my date, which is and I'm going to put in the time. And now I'm going to actually put my initials right in that spot. We only sign a MAR after we have given the medication, never before. This is a legal document, and we only use a black pen for any kind of documentation. Then I'm going to sign the master signature. And if you wanted to sign the master signature before you gave the medication, that part's fine. Just don't initial that you've given the medication until that's done. So I'm going to sign my master signature and my designation and my initial. I would go in and check on Jesse several times, especially within the first 15 or 20 minutes or so after the injection. I would tell him what to look for. If there was any problems at the injection site, I would certainly let the doctor know if there was anything wrong. I would document that. And I think that concludes our demonstration of an intramuscular injection. Thank you.